Good evening, folks. Welcome everybody to Medicine Today Live. This started out as a virtual series, but obviously we have an in-person event tonight in addition to the virtual series, and we're very excited for that. And really the goal in this series is to be able to highlight some of the innovative work that folks at Brown are doing in a variety of fields. So it's not just tonight's event, but it's a series that includes other presentations. We're very excited to be able to be supported with tonight's lecture as the Safiyah Family Lecture in OBGYN here, which was established in 2007 by Carl Safiyah, who's an alum from undergrad and the med school. So we appreciate the support. I'm Ben Brown. I'm one of the OB-GYN faculty members here. I'll be talking to you a little bit more later in the panel, but I want to give you a brief overview of the panel and the folks who are going to be speaking tonight. I myself am an OBGYN. I am the Pichey Assistant Professor of OBGYN here at Brown, and I'm also a subspecialist in complex family planning. So I have OB-GYN training. I work as a general OBGYN at Women and Infants, and then I also provide subspecialty care in complex abortion and contraception care. I'm also trained as a medical ethicist, and then just personally, I'm a Quaker, and my own kind of religious value system is part of what motivates me to provide the care that I do. And so I think you're going to hear about kind of all of those pieces and how folks are motivated to provide care and how folks are motivated to engage in caring for our communities, engaging advocacy and scholarship throughout the panel tonight. So I'm here, obviously not alone. I'm here with several wonderful colleagues who you'll hear from tonight. Dr. Safiyah Hosein, Dr. Carberry, and Dr. Vivian who will all introduce themselves as well, and will be talking about their own research and advocacy in clinical care. And I'll point out before I turn the mic over that part of what we want to highlight tonight is the ways in which our department, in caring for folks thinking about reproductive and sexual health care, how we work within a broad model of what health looks like and what health care looks like. And what medicine looks like. And that's, it very much meshes with the overall approach that we are highlighting in our work throughout the med school in the 50 Years of Medicine at Brown program, where we're thinking about clinical care, we're thinking about teaching, we're thinking about scholarship, and then we're also thinking about community engagement and advocacy. And I think you're going to hear about each of those things from the presenters on the panel tonight. We're also going to do a Q&A afterwards, so you're going to hear from folks individually, and then at the end, we'll invite folks to ask questions. And so please, if you think of things as we go, we'd love to hear from you at the end of the discussion. So without further ado right now, I'd like to introduce Dr. Safiyah Hosein, who's going to speak a bit about some of our advocacy and teaching work.
So as Ben mentioned, I am Safiyah Hosein. I'm a clinical instructor here at Brown and also a generalist OBGYN at Women and Infants. I have been here for about a year now, so still relatively new, but it was a coming home to me. I was an undergrad here at Brown. And so I also have a specific interest in family planning, just like Ben does. And that actually started from being involved in abortion care from the time I was a sophomore here, working at a family planning clinic in different roles. And I went into OBGYN to be an abortion provider. So that's sort of the role that I took. And then definitely an interest in working with residents and working with medical students. The thing that I was asked to speak to you all about was this idea of advocacy. And I think advocacy can look like a lot of different things and be a different avenue for different people. And for me, one of the ways that I think about advocacy is in sort of training the physicians that are going to come after us. And so some of the advocacy that I think I do is working with medical students. We have med students for choice, and both Ben and I have worked with them looking at sort of the ways to introduce the topic of family planning and reproductive health care, reproductive justice, and then also just working with students in the operating room and being able to have frank discussions about what abortion care looks like for patients and for their families and for their long-term reproductive health and goals. One of the things that I'm working on currently that I am really excited about is a research project with one of our residents. And that is sort of looking at the need for information about abortion and self-managed abortion, which is going to be more and more common with the loss of access in the different specialties and all the different sort of physician trainees at Brown, and what do they know about this care? What are their interests in learning more about this care? And then designing a way to speak to that and to teach and to really give the information to these providers that are going to go back into their communities, continue to care for patients who will need reproductive care and abortion care, and potentially be in states where they may be the person with the most knowledge and the most on hand, because there's not going to be a ton of access. And so I think sort of my view on advocacy is sort of sharing the information to people who are going to make their communities safer and healthier.
And I think as Dr. Sain mentioned, we work together in the family planning arena and are in the process of really building out a formal division of family planning at Women and Infants. And a key component of that is this intersection between the advocacy component, the community engagement component, and the scholarship. And I think that's another key aspect that Brown really brings to the table in this arena, and something that I'm particularly proud of in the work that we're doing in our department. My own research focuses on family planning policy analysis, using both secondary data, so large data sets, national data, regional data, and kind of statistical methods to understand the impact of policy on the one hand. And as I say, I'm also trained as an ethicist. And so on the other hand, the other major way that I try to approach family planning policy is to look at the ethical implications of a policy that's imposed. What positives and what negatives does a policy bring with it, using an ethics lens. And so I think combining those two approaches, hopefully we can get a better sense for how policy impacts real people. And particularly with family planning care being contested care in our current political environment, having solid data to understand the impact of policy for the people who are ultimately affected by that policy, I think is really critical. And so one of the things that's unique and really special about being here at Brown and being in Rhode Island is we're a small state. It's literally possible to get to know your legislators on a name basis, so that you know them and they know you. And there's a real potential for engagement with folks who are in the legislative process, folks who are policymakers in state agencies, folks who are advocates in various community groups and networks. And that's, I think, more possible here than it is in a lot of, or might be perhaps in larger states or larger cities. So one of the kind of very special things about the opportunities we have here at Brown is this ability to move data into practice and really be innovative in the way that we collaborate from a research setting to a policymaking setting or an advocacy setting. And I think that really enriches both groups, right? Certainly any research that I do is stronger for the input and the feedback and the collaboration that I am able to engage with folks in the advocacy and policymaking spaces, and I hope vice versa. I hope that by those of us who are engaging in research, engaging in scholarship and teaching, that enriches our contributions as advocates. So that's an ongoing project of ours here, particularly in the family planning setting, but writ large. Our hope is that as a department we can contribute to Rhode Island being a place where health policy around reproductive and sexual health care is patient-centered, and helps patients access the care that they need and helps providers be able to give the care that patients need. With that, I will pause there and I'll invite our next presenter to come up. I think it's Dr. Song next. Awesome, I'll step out of here right here.
Okay, nice to see everyone tonight. So I am a urogynecologist and I take care of women with pelvic floor disorders. Not a lot of people know about pelvic floor disorders because women are embarrassed and they don't talk about it a lot, but it generally includes urinary incontinence, pelvic organ prolapse, where the pelvic organs lose their support and they start to fall down, and bowel incontinence. And so there's a lot of stigma around these conditions. But that's what we take care of in urogynecology. We have a nice research program. We are part of a clinical trials network where there are 6 sites across the country. We're funded by NIH, and we do clinical trials on women for treatments and prevention of pelvic floor disorders. But I was asked to sort of talk about what I'm most excited about, and we have a ongoing study right now for urinary incontinence that has a pretty large community engagement component. The clinical trial part is, kind of comparing 2 treatments, Botox versus medications for urgency incontinence. But what's interesting about the study is our community engagement component. And that's what's new actually for urogynecology. No one's really done it. And certainly we haven't ever really delved into this in our state. The study includes 5 sites, including us, we're the lead, and then New Mexico, Alabama, San Diego, and then Howard University. And so if you envision, all 5 of those states have different communities in terms of needs and in terms of how to outreach and how to engage those communities. So they're pretty different. Like here in Rhode Island, we're a small state, but even though we're small, there's still big barriers, right, for women to make it to see a urogynecologist. In New Mexico, we have this one slide in one of our presentations. Women are coming from pueblos, and if they have to come, to city center or to the medical center, it's a long ways for them. It could be, a 3-hour drive easily. And there is an abandoned building between one of the pueblos in the, it's like midway in this drive between the pueblo and the medical center. And it's the common stop for women to stop and go to the bathroom, in the middle of their drive, and then continue their drive home or continue their drive to the medical center. And so, it really does obviously have a big impact on women's quality of life. And then, Alabama has, an underserved population, as does San Diego, as does Howard University. And so we're really trying to engage our communities to try to, to see what the barriers are for getting care. And so this particular study, we're starting out with community engagement studios. The first set of studios is actually with providers in the communities, mainly primary care providers. So we're really targeting physicians and providers, even, clinical staff, interpreters, anyone who has patient contact, to participate in these studios where discussions have happened about what resources do they need to provide care for women with incontinence, for example. What are their barriers when they're trying to take care of a patient or send them to the urogynecologist? What is the difficulty? What barriers do they encounter? And we've gotten a lot of really interesting information. For example, we actually, just as this just came up this week, we have asked them to review some of our pamphlets that we hand out to patients. And they looked at it, and some of in the patient studios, this came up as well, and they supported it. They looked at it and they said, all of the women are smiling on this pamphlet. And this doesn't make sense. But those are pamphlets made by our marketing departments, who we trust. They know how to market, what we're trying to advertise. And they were like, this doesn't speak to me, it doesn't speak to our patient populations. And that was like really, really good information. The other thing that our study did is we're used to designing trials that are very researcher focused. So a bunch of researchers get together, they decide how to do the study, they decide what the outcomes are that should be measured in the study, and then they say, hey, listen, we're doing this study, they do the study, and then they publish the results, and clinicians look at it or people look at it and they're like, what does that, like, I don't understand why the study, measured this, or I don't know how to use this information. And so our trial actually started with patients from the very beginning. So we had a patient expert panel, 2 from each of the states, from each of the 5 states, diverse panel. And from day 1, when we even applied with a letter of intent, they have been with us. They have been guiding us. We said to them, we're doing this trial, we're comparing Botox and medications, and we're thinking the primary outcome should be the survey that's always used in every single incontinence, in most of our incontinence trials. And these are the surveys that we usually use. And they looked at it and they were like, yeah, this one, that doesn't really, speak to us, but this one's good. So they helped us actually choose the outcome. We're like, okay. And they said, but that wouldn't be complete for me as a patient to decide between these 2 treatments. And we were like, oh, tell me more. And they said, to me, treatment satisfaction is also really important. So Botox versus medications, there's things that can influence whether I am satisfied with that treatment. What do I have to go through to get that treatment? One's a procedure, one's a medication. Maybe someone may value different things that aren't captured in just, is my incontinence better? And so we also added a treatment satisfaction survey, and we went through a bunch of satisfaction surveys, and they helped us pick what to measure. And we said, okay, choose which one's most important, the treatment satisfaction, outcome, or the incontinence symptoms. And they said both. And so we actually designed the trial with that input for those to be 2 co-primary outcomes, and powered it based on their input. So they've been along the way designing the study from day 1 with us all along the way. And so it is truly patient-centered. It truly speaks to the values of patients. And that's just one example of how, we're really trying to engage patients and engage our stakeholders along the way. So that's sort of where we are there. We're in the middle of patient studios right now. I'm again, it's probably the most exciting thing that's going on right now for, that I'm excited about, because it's different and hasn't been done. We don't know a lot about how to engage our communities, and so we're learning all along the way. I think that's all I have. Yeah, okay. And I'm going to introduce Dr. Cassandra Carberry. She goes by Cassie.
Dr. Sung and I have known each other too long, obviously. I thank you so much for having me. This is very exciting to be part of this. I'm Cassie Carberry. I too am a urogynecologist, as you may have figured out. And my other job is I am the clerkship director for OBGYN, and I'm going to talk in a minute about what that means. But I'll just say that, I did all my training in New York at NYU, and then I came here almost 14 years ago, and I've been here ever since. But the running the clerkship has been a somewhat newer endeavor. I think that started in 2019. So a core clerkship is the model currently for the curriculum at the medical school, and I know that some of you out there know this better than I do, is that when students are going into the patient care space, so now they're part of the patient care team, that's their job all day long. They have a lot of time for exploring the things that they want to do, but they have also very foundational time that they have to do. They have to engage with certain specialties. And those are internal medicine, pediatrics, general surgery, family medicine, neurology, psychiatry, and OBGYN. So it is not an option. It is something that every single student will go through, and that is obviously something that our department very much feels is important, and the medical school feels is important. And it's not that unusual. I think almost every medical school in the country probably has that model. I think that what feels different to me about our clerkship is that we have done a very good job of engaging students, and I think we have built a clerkship that seems to be very highly rated, and so I will not take credit for that at all. I had inherited this from very capable hands. You guys might know my predecessors, Dean Hampton and Dean Breeze. And also the faculty and the residents are just absolutely amazing teachers. But we do tend to do very well as compared to our peers nationally in terms of the ratings of the clerkship. And maybe most importantly, as a metric, we attract, probably over a dozen students every single year into the specialty, which is, why I want to do this job. I mean, I want people who care and are passionate about this to go on to take care of our patients. So that's really the exciting part of it. I think one of the things that I was asked to kind of discuss is how has that curriculum changed and grown and everything in the last, however long, 5 to 10 years. And I think that for me, some of the most important things have been how we have integrated ideas around equity and inclusion and really trying to bring those into the curriculum in a way that isn't, a one-off lecture or a topic that you talk about once and then it never comes up again, but really trying to weave it in and make it integral and have every student come out with an understanding about how that's important and how that's going to affect every patient interaction that they have, right? I mean, this is really, really foundational to what we do. And that's part of why I always make a very corny joke during orientation that even if they make the mistake of not doing OBGYN for their career, they still need the skills, right? So even if you are a primary care provider, you need to know how to take care of a person that presents with vaginal bleeding or abdominal pain or whatever the case may be. But I think the other thing that's a really interesting opportunity for our students in our environment is to practice having really difficult conversations with patients. I go through the objectives with them and it's one thing to understand the content that you have to try to get through. It's another thing to realize how to build a rapport with the patient that allows them to talk to you about their sexual history of trauma, any of those things that are really going to be important to them. And that, that's a skill and that's something that's really important. A lot of the things that Dr. Brown was talking about is shared decision making. So in order to be able to not just, decide for the patient what's important, but actually hear them and meet those shared goals, that, that's a skill that they really get to practice when they come to OBGYN. So I think that we've tried to do a lot and it's a continual work. I mean, this has to be a work that is ongoing in terms of the curriculum, faculty development. Students have been absolutely crucial to those efforts. I think there are a lot of examples that I can think of where without students' input, if not initiative, things would not have happened. I think probably it was about 4 or 5 years ago that one of the 9 abilities, so if you look around the room, you'll see these posters, and when you came through the door, there's the 9 abilities. So these are, the foundational things that all the curriculum is structured around, as well as how the students are evaluated. And one of those abilities, ability 7, was changed to health equity and racial justice. And that, I think, is very illustrative of this focus and this need to really make it integral and part of the curriculum in every way. And so I think for our part, we really try to reflect that by adding, didactic and patient care content around the care of transgender patients, care of patients with disabilities, abortion care, and I personally give a lecture on racism in OBGYN, so I think we are trying very hard to to live up to our mission. The students, actually, a 4th-year medical student designed a reproductive justice curriculum, and that is part of orientation. So they hear me talk at them for an hour, and then they have a much better lecture from a 4th-year medical student, and that has been taken over by the next year of 4th-year medical students. So that, I think, is very exciting, and also, again, kind of emblematic of the work that the students do and how important that is. So. Another role that I have in the department is relatively recently becoming the chair of our Diversity, Equity, and Inclusion Committee. And that, I think, dovetails very nicely with this because it doesn't make any sense to sort of have efforts on one hand that, the other hand isn't receiving. And so the hospital, the faculty, everyone that students are engaging with and patients are engaging with for that matter have to sort of have this shared shared set of values. And so it's exciting to be able to do that work and to feel like, they're aligned in that way. So that is sort of my stuff. Should we?
Yeah, so let's,
move on?
so
Okay.
we can move to the Q&A. So,
Okay.
thank you. So we'll move, we can have everybody come up here and then we'll do some Q&A, and we can take questions from folks here. We also have some questions that folks submitted online. I'll also point out actually a number of the initiatives that folks have talked about over the course of the conversation tonight have been funded in one way or another through the Women's Reproductive Health Fund, which is a fund here at Brown to support work in reproductive and sexual health care, and particularly education and program growth in those areas. So if hopefully something in the various dimensions of what we've talked about and will talk about tonight has sparked your interest, and if you want to support that work, there of course are ways that you can help to do that, and the folks from Advancement can talk to you about that. And again, we all recognize, I think I can speak for everybody here, that we all recognize how, what a tremendous gift it is to have a program set aside for pelvic floor disorders, or to enrich the medical student education, or to support family planning policy. We know that doesn't happen just by accident. It happens because people are dedicated and want to support it and want to help grow it. And I don't think there's anybody in academic medicine who doesn't have at least some level of awareness of how special those things are when they really come together. And we're really lucky at Brown that we have great support for that and a great community that helps to build that work. So thank you for everything that you folks do for that. But yeah, well, if folks have questions, you're welcome to come up to one of the microphones here and ask them. While we're prepping for that, I'm gonna start with the pre-submitted questions for folks. I'm trying to think what the best one is, because we've covered a lot of ground that folks were hoping to hear about, which is kind of exciting. So I'm trying to make sure that I'm not going to ask you to rehash something that you've already talked about. Well, here's a good one, maybe for you, Dr. Carberry. How this is from somebody who's an undergrad. How can folks get involved with reproductive and sexual health care work who are undergrads, or just who are kind of in the process of kind of finding their career path?
That is an unfortunately not as easy to answer question as I would hope. I think it's been a little bit complicated because of COVID, to be honest. I think that we have had a lot of limitations in how we can integrate learners into the space, and our own hospital policies have, sometimes been a little bit harder to navigate with bringing in people from the outside. The other struggle is, of course, making sure that the students who are already there are not compromised by other learners. But I think the short answer to that is reaching out to me, or to if you have a mentor in the department or you know someone, you can always reach out to them, but you can certainly reach out to me and we can try to figure it out. I would also, if it's not necessarily clinical exposure, if you just want to meet and kind of pick someone's brain, I don't think there's any faculty that would not be up for that. I mean, that's something we're very happy to do. We love to talk about what we do every day and sell it. So I think that's not hard to do. There is through the OBGYN interest group, I think, right? So second year, but that's second year medical students. You're talking about undergrad. So I was thinking there are opportunities for pre-clerkship students to get involved through the OBGYN interest group. But for undergrads, I would say, I want to say, I'm not sure. There was a person that I thought was the contact person, but you can reach out to me, and I'm happy to figure out what we can do, if it's like a very limited shadowing kind of situation, or like I said, something more informal. That can always be arranged. It just is there's not necessarily a formalized process for that.
I was just gonna add that we've had undergrads do research with us in our division. So, we've had learners all levels come work with us.
Awesome.
When they come to you, Vivian, how do they know? Is it just through like a posting that they know to get to you?
No.
How do they
Most
find
of
you?
them, well, sometimes it's word of mouth.
Okay.
But sometimes they've contacted me just directly. I don't know how they find me.
who thinks.
I
Do you
don't
have
know.
a profile on researchers at Brown?
Yes, I do.
Yeah, that's, I know people that found me on there.
Yeah, so
Yes,
sometimes
that's
they
good.
just find you and then it works out.
Yeah.
And if it doesn't, usually we can refer them to someone else, like if we don't have room space or room in that moment. But I know we're pretty busy right now, but we usually can refer them to someone else.
And I'm gonna be that person who's like, back in my day. So back in my day, there was a thing called an UTRA. Is that still a thing? Undergrad
Yes,
teaching
New
and
name.
research assistantship? Okay, great.
different name, same concept.
Great, perfect. So there's funding. There's funding through Brown. So particularly if you're like, oh, between my sophomore and junior year, I'd like to do a project on something, Brown can help you support you in that too. I don't know, Dr. Hosein, maybe, do you wanna maybe take this one? I don't know if you feel, I think this maybe clicks with kind of some of the stuff you're talking about with education. Someone asked, what's the future of the sex education field in the US? And what careers can interested scholars hope to pursue? I wonder if that dovetails with some of the things you were talking about.
Yeah, I think those can be very different things. So, I mean, if you think about sex education broadly, there's the idea of it in the schools and in the communities. I always hope that people aren't getting their first sex education from their OBGYNs, though that is possible. But I think what we've at least shown through all of our research is that education is important. Abstinence-only sex education does not have better outcomes for individuals. And so being able to just empower the younger generation to have information and be able to access that. And I think social media has been a great way. There's obviously like supported programs from more like national organizations, but just information is always better than not. And they've also shown more recently that there's data looking at like onset of first sexual encounter and information around contraception in like generation Z, is that the little one right now?
It's another of our oh yeah, we're progressing out of we're not the young kids.
But like, they've shown that like the generation of people who are in high school and in early college now are making more informed and somewhat safer decisions around their sexual health, which is great.
I wonder, I mean, and I suppose this could be for both of our Euroguide panelists potentially. We talked a fair amount about kind of the research side of things and the community engagement side of research, but a couple of the questions addressed what does care for folks as throughout the lifespan look like around pelvic floor disorders? Like, what does that kind of care look like, and what are some ways that that an OB-GYN might be helping support someone to have good pelvic health throughout their lifespan?
You want to start?
No, you go ahead.
I mean, I think we happen to be very lucky here because we have such a long-standing program, and I don't know that that's true everywhere. And I think we have benefited from great leadership, and it has meant that doctors in the community are aware of us, and so they can feel like if anything comes up in a visit about incontinence, about any of those concerns, they know where to go. And I think that's really important because awareness is definitely a big part of the problem. I know many of us have been involved in also doing kind of community outreaches. I've gone to local retirement communities and things like that to just talk directly to possible patients and answer questions and just kind of give them information. Because yeah, like Vivian said, these are not topics that people love to talk about. So the more that we can be the one to start the conversation and say it's okay, and we have some answers, and sometimes we don't have all the answers. I think that's really a crucial part.
Awesome, thank you. I'm gonna take one of the questions and give my own response to it, but obviously I'd love to hear other folks' thoughts too. Someone had written in ahead of time and had asked why we assumed that everyone in the audience would be pro-abortion. And I would say abortion is essential. Abortion is essential healthcare. And that's not just me saying that, it's the American College of OBGYNs saying that abortion is essential healthcare. Reasons that somebody might need an abortion as there are people seeking abortion care. And some of those reasons are foreseeable, and some are unexpected. And we have a responsibility as healthcare workers to make sure that people have access to that care when they need it. So I'm pro-abortion in the same way that I'm pro-insulin, or I'm pro-hip replacement. These are treatments that people need to have access to when they need that treatment. And to me, that's not negotiable as a matter of healthcare access. That said, every day when I'm caring for folks in the clinical setting, my first and foremost responsibility is to understand what that person sitting in front of me, what their needs are, what their values are, right? And to be able to tailor the course of care, provide that person with a course of care that fits with that value set and with those needs. And so you can easily imagine that every day there are multiple people who are faced with similar health circumstances and are opting for different courses of care based on what their individual needs are and what their value set is. And that's what all of us are doing every day, is making sure that the person who's sitting across the room from us, that they're getting that care, that they have a provider who's listening to them and who's honoring their value set and making sure that they get the care that they need.
Thank you for that answer.
Yeah, for sure.
Dr. Sandra, a question came in for you over Zoom. So this person says, thank you for your very important work in pelvic health and especially your community engaged participatory research. I'm wondering about prevention and whether we might be engaging in pelvic health physical therapy programs in the perinatal period as a preventative approach, as is commonly done in Europe.
Great question. We certainly support peripartum or antepartum pelvic floor health. I will say that the way things are structured here, there is a little bit of disconnect. Like, we don't see patients when they're pregnant. They're taken care of by their obstetricians. But that being said, we actually do have and we're working on building a very comprehensive peripartum program. Right now, we have a peripartum clinic, actually, specifically in urogynecology, where we can see patients either before or after they deliver. Right now, I would say the majority of patients are after delivery, but there's definitely a lot of attention and effort in anticipation that program's going to grow. So.
Hi, thank you all for this wonderful talk and panel. I have a question just about the current political climate and the restriction of access to abortion care and how you think that's going to impact residency training in OBGYN.
So it's obviously going to impact the way that we train our resident physicians. Even just thinking, so the way that residency works, there's this core set of competencies that residents have to meet to graduate and sort of be board accredited and certified, be able to sit for their boards. And one of those is training in abortion care and training in D&Cs, D&Es. And so if that training isn't available, how are you going to meet that competency? They've also shown, like, even just in more recent studies, looking at sort of preference for where people want to train and where they want to match. And even people who are not going into an OBGYN specialty are saying that they're preferentially choosing states that have access to care. And that could be for a number of reasons. One, they want to be able to provide that care or talk about that care to their patients. Two, they're young reproductive age people themselves who want to be able to access care if they need it in their training. And so they've already shown that skewing where people are thinking of applying or thinking of matching. And that can also just continue to worsen the health disparities for their communities as well. So if you're having top candidates not apply to states where they can't access or talk about that care, then you're going to have more health inequities for the communities, especially the communities of color in those states. One way that we're working on that, and it's not always doable, is at least in OBGYN itself, is some shared sort of like exchange programs, more visiting aways, We here at Brown are a Ryan program, which is just meaning we have a specific designation that we provide care and family planning. And so the Ryan program themselves are working with the places that have already designated as family planning sites to be able to sort of exchange residents, but that has all of its own complications, including things like state licensure. So being able to have universal licensure for residents would be instrumental in being able to get people access to care and allow them to move across states to get the training that they need. So it's definitely going to affect it. We can't see the full ramifications yet, but it's already starting.
I was just gonna add that I think it's tough waters to navigate, and we are really trying to provide a lot of information to applicants because at this point, it's down to individual state legislation. I was talking to someone who is faculty at the University of Texas, and they were recently told that they are not even allowed to say the word equity in a meeting. So I think it gets really, this is something you have to know before you go somewhere to train and take care of patients. So and I think it's going to require a lot of partnering.
I have another question off of Zoom. Do you advise away rotations in OBGYN?
I'm not sure if I understand the question, but do we advise our own students to do away rotations? Sometimes. It depends on the scenario, and there are definitely benefits to going to another institution to see how, things are done differently, to just pushing yourself out of a comfort zone. That there's a lot to that. Do we bring other people here for away rotations? We also do that, and that of course is up to those individuals, institutions, whether that is part of what they are able to do, but they can do that through the medical school.
Another one of the questions that we got ahead of time, which I'd be happy to hear from anybody who wants to talk about this. How do we ensure the inclusion of the experiences of trans and gender diverse community members in discussions such as these? How do we ensure that all medical students learn about these communities in discussions of sexual and reproductive health? And I think both broadly and then particularly in terms of kind of maybe the role of OB-GYN as a field specifically in providing care to folks of all genders.
As I mentioned, we have mandatory didactic content on the care of transgender patients, and I think as faculty, we've all undergone some training, and that's ongoing. We do have some faculty who specialize in the care of transgender patients and gender affirming surgical procedures, and so students are certainly participating in that. I believe that also in the pre-clerkship curriculum, there's a lot of discussion of that, and there's more attention paid and probably more time given just because, they're with us for 6 weeks, but they're doing their pre-clerkship studies for longer than that. So that's what I think their primary exposure as far as with us.
Again, this happened before I got here, but I'll also offer that I think that language has a real, it holds a lot when thinking about caring for diverse populations. And so even like the resident-based clinic where I provide my care out of used to be called the Women's Care Center, is now the Obstetrics and Gynecology Care Center, because we understand that people other than women need obstetric and gynecology care.
For sure. This is also something too. I mean, one of our kind of closing questions. I'll jump to the end just for a moment because I think it fits with it well. Is what do folks think about is kind of next for the field of OB-GYN? And part of my thought about that is that I think that so my subspecialty complex family planning just became board certified this year for the first time. It's a long process. We're thrilled that we're at that point. And so, but it also kind of begs the question, what's next? And one of the things that I've thought about from my vantage point is, we don't have a specific home for sexual medicine in OB-GYN. I think, in some ways urology has led the way with that, where there's a sexual medicine fellowship, which is focused on sexual wellness, including things like sexual pleasure and erectile function and things like that. And we don't have as much of a clearly defined kind of nucleus of that, I think, in our field. And I think it'd be great to build that. And I think likewise, finding ways where we can kind of very in a kind of a sustainable and a kind of institutionally strong way, show our commitment to the way that we think our field needs to participate in gender affirming care and in a number of facets of medicine around sexuality and gender that have kind of, I think, perhaps been shoehorned. We've shoehorned away from our specialty because we thought of ourselves as women's health, and we need to embrace a more kind of holistic definition of that.
Yeah, I would echo that, and just continuing the fight to recognize the value of caring for this patient population. You know, there's a reason why urology has men's, sexual health, men's sexual health focus, because the reimbursement is there, the research is there, the attention is there, and it's just not equivalent for, the patients that we take care of and the population that we take care of. It's just not the same. And, fighting, continuing to fight the fight. I think just as another example, there are protocols for just as simple as testicular torsion. But then for ovarian torsion, there's not the same expected protocols for rushing someone to the operating room, saving that ovary, all that. But there is on the other side, and it's just the trend. It's just the same story, a different chapter. So I think for OBGYN is us just continuing to push these issues and recognizing the value of the patient populations that we take care of. And just continuing to do that fight.
I think what I'm most heartened by is the things that Dr. Sung is doing, and listening to patients and letting them really be at the forefront of our research and our care, and trusting that the patient knows themselves and knows what's best for them. And I think medicine in general has a history of being very paternalistic, and I'm hopeful that the future looks different for the patients that we provide care for.
Yeah, I'm not sure I could add to that other than I do think that a reproductive justice framework is also something that I hope and would foresee becomes, something that reaches beyond OBGYN. I think it really is something that, by definition is asking us to look at our patients as a whole person and the structures that impact them in every way and how that impacts their health. And that isn't, confined to their genitals. It has, it impacts every part of them. So I think that's something that, I am very glad to be part of doing that work with Brown. And that's really, again, I feel heartened by that. Yeah.
I see another question from
Somebody online is wondering what research is happening at Brown around pelvic pain.
Great question. I don't think any of us is directly involved in pelvic pain research. I know Dr. Foley has a number of projects ongoing. I'm not sure I can speak to the details of them. Does anybody know?
I don't know what exact research she's doing, but I do know that the department is in process of building and adding to to caring for pelvic pain. But Dr. Foley is an endometriosis and pelvic pain specialist, adding to minimally invasive surgeons as well to that group, but also looking to add someone who very much focuses on other non-surgical pelvic pain conditions also. So that is an area of growth also. So the research, I have no doubt, will come with the clinical growth, but you have to have the clinical setup first in order to sort of also have that research growth with it. So
I really appreciate your comment, Vivian, though, about the structure. I think that we do have to say that part of the problem with these things is that there has been no incentive for healthcare to provide these services, and there's every disincentive. So I think that's a bigger systemic change.
Know that a vulvar biopsy pays very little, but a testicular biopsy or an equivalent male biopsy pays way more. And it's there's no rhyme or reason other than it's in a woman.
The maybe perhaps building on that, I think obviously I think it's very clear what the some of the key advocacy areas that we're interested in and that we see going into the future for the field. But someone also asked specifically, what does going into OBGYN look like these days? And so I think we've maybe given a pretty solid explanation, hopefully, of some of the advocacy components and some of the areas that we see for growth in the field and growth, in the field as organizationally. But I don't know, maybe Dr. Hosein, you want to talk a bit about kind of what the day-to-day life or the training process becoming an OB-GYN looks like, perhaps?
Yeah, I am the one most recently in training. I guess what I would offer, the thing that I love about obstetrics and gynecology, and that I think many of my colleagues can echo, is that it really can look very different based on what you do. So my day-to-day likely looks very different than what Dr. Carberry does, what Dr. Sugg does. Dr. Brown and I do somewhat similar things. And so there really is space, if you're interested in the field of reproductive health, reproductive justice, that you can sort of carve out a niche for yourself. And so, like I said, I have an interest in family planning, and so I do that not only in my role here, but also at independent clinics in the area. That's sort of the route that I took. And then you can be a researcher, you can essentially be a primary care provider if you really want to. Dr. Foley, who we mentioned, is a minimally invasive surgeon who specializes in surgery, but also endometriosis and pelvic pain. We have menopause providers. We have people who specialize in vaginismus and vaginitis. And you can operate, you can see patients in the clinic, you can run the emergency room like Dr. Brown and I do sometimes. So there really is so many different ways that you can be in this specialty, which I think is really unique and special about it.
Yeah, and I'll just tack on, in line with that, it's a privilege to take care of, a woman in any of those phases of her life. Think about what, all the phases that she goes through, and to be part of any of those is just a privilege, and it's the best field ever, really.
We are all biased because we all really do really love the field of OBGYN, and we think it's great, even though we see ways for it to grow and get better.
Yeah.
We also think it's really great. So you're gonna hear a slightly biased answer from all of us about that.
Yeah. I always tell students, of all my friends in residency, none of us have the same job. Nobody, even with the same specialty, have the same job. It's just, it can go so many directions, and it can change over the course of your own career. So it's that's, I think, very nice.
That's an excellent point, because I think and I think people intentionally do that, right? Being on call for deliveries overnight is hard, and so I'm told gets harder as you age. So so people change their balance, right? People change the balance of what works for them at different times in their career, and that's because we have a pretty diverse field in terms of the various kinds of care that we can provide. There's flexibility for that in a way that there might not be actually in some other fields, which is very cool.
It's all about what gives you energy, and that's different for everybody. So you just got to find that.
Well, I think we're largely coming to the end of kind of prepared questions, and it sounds like questions online. I don't know if folks have any kind of closing thoughts, words of wisdom, things you wanted to share, things you didn't get a chance to say that you wanted to say.
I did fail to mention in response to the question about away rotations, that we do have a specific program designed to allow students who are underrepresented in medicine to come to Brown and do what's called a sub-internship. So that's a special elective in the 4th year to really focus on a subspecialty.
I guess my closing thought is just when thinking about reproductive health and reproductive justice, we all know that Black women are more likely to have maternal morbidity and mortality, and it's everyone's job to make sure that that gap closes.
My closing thought, I guess, would be to learners. I think if you're interested in anything, even though if it's not OB/GYN, that's okay too, I would encourage you to reach out to mentors, to reach out to people. Like, everyone is, I feel like, super, wants people to succeed, and don't be afraid to reach out. I mean, the worst that could happen is someone might say, oh, I don't have time for this, but let me direct you to somebody else. And so never be afraid to do that. I think that works really, really well. Never be afraid to reach out to someone you might find online, or even not at this institution. That's worked really well for me in the past too. Like, I've never had anyone be mean, and they'll usually direct you in the right direction.
I will say we are very lucky. We have, particularly in our department, we've got a lot of really nice people. Like, which makes a difference. When you're working long hours or you're working hard to take care of folks, it's nice that your colleagues are nice. It means a lot, actually, having worked in places where sometimes that happens and sometimes it doesn't. Thank you, everybody, for coming. Thank you, everybody, for coming. And thank you to the Safiyah family for funding the lecture. And we'll be around for a little bit afterwards if folks have other questions or want to touch base individually. Hope everybody has a lovely evening.